Hello everyone and welcome to Waveform Capnography. My name is Kate Marquis. I'm a nurse at the Life Support Learning Center at University of Virginia Health System. And again, this is kind of the basics of waveform capnography. So if you've never heard of waveform capnography, if you've never seen it before, or you really only kind of have a vague idea, this is a great place to start. We will be doing 2 more videos following this, which will kind of get into more of the advanced stuff, but we're going to stick with the basics here to give you guys a nice little building block. The links for those 2 other videos will be in the comment section below. So let's get going here. Objectives, always have to have objectives. And these objectives are really for the entire series that we're doing here. So today we're going to define waveform capnography. We'll talk more about the uses and the ability to correlate changes in our patient condition in the next couple of videos. So let's talk definitions. Start from the beginning, right guys? So I'm an ED nurse by trade, so what I learned was air goes in and out, blood goes round and round, and any interruption in that process is probably a problem. So this gets a little bit more specific into that kind of basic stuff. So we talk about what ventilation is and how it's defined. It's the active mechanical movement of air into and out of the lungs. Whereas diffusion is the passive movement of gases from an area of higher concentration to an area of lower concentration. We'll talk a lot about that when we talk about gas exchange on our alveolar membranes here. Perfusion is the movement or flow of blood through the circulatory system, which results in the oxygenation of tissues, right? So after air goes in through the lungs and after it's passed along into the capillaries there, the capillaries take it into the full-on circulatory system and we're able to actually oxygenate those tissues, those organs and everything else there. SaO2 is the percentage of red blood cells with hemoglobin bound to oxygen, right? So this is the arterial blood draw measurement, what our oxygen saturation really is. SpO2 is the happy little thing that we put on people's fingers. Our pulse ox will measure this. Measures the oxygen saturation in the periphery. Now it may get a little wonky, right? You talk about carbon monoxide and other things that can kind of make that reading go awry. Capnography itself is the measurement of CO2 at the end of exhalation. And this is going to help us measure ventilation, that active mechanical movement of air into and out of the lungs. So let's talk a little bit about A and P, right? Kind of good to know where we start from. So inspiration, we get a signal from our brainstem here. Our diaphragm contracts and flattens, which creates this negative thoracic pressure. So this is drawing air in. Our chest wall will then expand, and then we will have gas exchange, begins at the bronchi and the bronchioles, and will go down into our alveoli and our alveolar sacs and all of that kind of good stuff. And you'll actually get that exchange the alveolar, at the side of the alveoli rather, the capillary beds there. This is an active process. Whereas when we move to expiration, our diaphragm is going to relax. Because our diaphragm relaxes, we have all that positive pressure there, so air is going to be expelled. And this is the CO2. When our lungs recoil, we're expelling CO2 here. So again, looking at that alveolar membrane where the capillary beds are, they're dropping off oxygen, they're picking up CO2. That's the diffusion. And we're actually able to expel that CO2, and this is a passive process. I do like to say a word on pediatrics because if you're listening to this, you may take care of pediatrics. You're pre-hospital, maybe you're a nurse who's working in pediatrics or something in between, what have you. Little kids, the children, if you will, they have larger heads, right, and comparatively smaller airways. So in the adult patient, what I would do to open up the airway is I would kind of tip their head all the way back. Again, assuming they don't have some sort of spinal cord injury there. Tip their head all the way back to do my head tilt chin lift. I can't do that in pediatric patients. I'll actually occlude their airway. So in the really small guys, the infants, we're just going to put them into that sniffing position. Other things we need to kind of think about, what does it mean when we have comparatively smaller airways? The airway diameter itself is smaller, which you can kind of expect, right? You look at a little kid versus an adult just in terms of the size. So their airway diameter is smaller, which means that a little bit of swelling here or there you talk about things like allergic reactions, is going to make a significantly bigger difference in that small child than it will in that adult. In kids, their tongues are comparatively bigger, and they have a shortened neck and trachea. The big thing to consider here is that children have decreased pulmonary reserve when compared to their adult counterparts. Now, I don't know how many of you guys watch Looney Tunes or have ever seen Looney Tunes. I suggest YouTubing it if you haven't. You have the Wile E. Coyote, and he likes to chase down the Roadrunner. So Coyote goes and he's chasing after the Roadrunner. He's going fast and he's going good and he's just about to catch the Roadrunner. And then the Roadrunner stops and Wile kind of keeps going and Wile ends up going off a cliff. And Wile realizes he has gone off the cliff, so he throws up his little help sign and kind of falls a great deal into this ravine. Kids are kind of like that. They do really well, they compensate really well, and they're wonderful, and they're just going strong until they can't compensate anymore, and they fall off that proverbial cliff. That's what this is referring to here. They won't be able to maintain for as long as an adult. So what is end-tidal CO2? Well, let's talk about end-tidal CO2 in this waveform capnography. So waveform capnography is measured as end-tidal CO2, and what we're really looking at is the partial pressure of CO2. This is non-invasive, which is fantastic, right? We try to limit the amount of invasive procedures that a patient will need during their care, and this is reflective of ventilation, perfusion, and even metabolism, and we'll get more into those kind of aspects in later videos. So we have a couple different devices here that we can use to measure our waveform capnography and our end-tidal CO2, one of which is called a side stream. So this is measured indirectly. A lot of times you'll see a nasal cannula with this round little piece that kind of hangs off the prongs of the nasal cannula. This is for spontaneously breathing patients. Kind of the issues that you can get with side stream are people who are mouth breathers. So instead of breathing out their nose, or they're unable to breathe out their nose, they just breathe through their mouth. It doesn't pick up quite as well, so a lot of times you'll actually have to adjust the device down so it almost hangs into the patient's mouth, and it kind of gets annoying for some of the patients. So just kind of things to keep in mind. Look at your patient when you're selecting your device. Another kind of device is this mainstream one. This is a direct measurement. It's in the airway usually. You'll see this on patients who are being bagged with their bag valve mask or intubated. It has a happy little connector there that will actually go into the device itself so it can read the end-tidal CO2 there. So let's talk about this waveform. So you put the device on the patient. Fantastic. You know, what am I looking at? What am I looking for? So this is what a normal waveform looks like, and I want you to take a look at this. It's kind of boxy, right? It's rectangular in nature, but it's not a perfect rectangle. I want you to really notice that. You can see this place here marked alveolar plateau. It's around phase 3 there. You can see the 3 little hash marks there. It is slightly angled up, and that's important because a completely flat box will tell you something different than one that is slightly angled upward there. So keep that in mind when you're looking at your waveforms, and especially when we get into our next lecture, which talks about alterations, common alterations in our waveforms here. So what does all this mean? Why is it a box? So basically what we're looking at is our respiratory baseline. We start at 1 here all the way to the left. And this is inspiration. The patient is still breathing in, taking that big deep breath, and our tracing is at 0 at this point. Phase 2, you can see where that first part of the box begins there, is our expiratory upstroke. That is essentially just where expiration begins. Phase 3 is our alveolar plateau, and you're going to see a uniform PA CO2 throughout. And again, it's slightly rising. This is where we've seen, we've gotten past kind of the alveolar dead space, and we're actually getting CO2 consistently through our circuit here. Then we move on to phase 4 there, which is where inspiration begins again. We'll measure end-tidal CO2 right before we begin phase 4 there. So you can see it's in that upper right-hand corner of that rectangular figure. So some significant numbers here. A normal end-tidal CO2 is between 35 to 45. Less than 35, we're thinking the patient's hyperventilating, they may have an airway obstruction, could be a myriad of things. And again, we're going to talk about these in a little bit. Greater than 45, I'm thinking the patient's hypoventilating, maybe they have some sort of bronchospasm, something weird is going on. So these are kind of things you want to keep about. These are kind of your normal hot numbers. Readings below 20 or above 50 are associated with poor outcomes. I really don't want my patients to have kind of like these extremes in this range here. But I do want you to keep in mind that end-tidal CO2 is a tool here, okay? And the tool is only as good as the person who's using it. So you need to keep in the back of your head that this isn't going to be perfect. You can't just be like, okay, the patient's end-tidal CO2 is 32, that's bad, I have to act on it right now. You have to look at your patient and you have to say, why is my patient's number reading that way? Okay? Because there are some things that may make a slightly low or slightly high number okay. And an example of that is a pregnant patient. They may have a normal PaCO2 of 26 to 34. Okay? That is low. It is below our low end of that range, right? So alterations from your baseline, that 35 to 45, should prompt your evaluation, but it's not one of those things that you go and you take to the bank that every time they're below these range, that there's going to be a problem. Okay? So we do have some significance of these numbers. If you're looking just in general, things to keep in the back of your head, things that'll show a decreasing end-tidal CO2, such as cuff leaks, cardiac arrest, pulmonary emboli. You may see some of these things, increased or increasing EtCO2, malignant hyperthermia, hypoventilation, bronchospasm, or even ROSC. So these are great indicators kind of on how my patient is doing. And I want you to keep in the back of your head that it's literally a tool. It's here to paint a picture for you on how your patient is doing. All right. You look at your SpO2, you look at your blood pressure, and what we do with those numbers is that we trend them, right? Those numbers over a period of time, whether it's your couple-minute transport, your couple-hour transport, or maybe it's your 12-hour shift, they're all painting a picture for you on how your patient is doing. You can sit there and trend those numbers and see the direction in which your patient is heading. Yeah, my blood pressure is getting a little bit low, and a little bit lower, and a little bit lower. And over a period of time, at some point, a red flag hopefully will pop up and be like, my patient's blood pressure is going down. Same thing here. Use it as a tool. All right. Oh, I see my end-tidal CO2 is trending down. Do I need to worry about this? Or maybe it's trending up and my patient might be going into respiratory failure. I kind of got to keep these things in the back of my head here. So if you do see something weird, check your patient. Go check your patient. So is this something I'm expecting to see based on the patient's clinical presentation, based on what I know is wrong with them? Is there a clinical reason why my numbers are all weird like this? Or has my patient started to deteriorate? And if you go through and you assess your patient and life is good, then it's time to check your device, right? I don't know if you guys have ever seen toothbrush VFib. It's when you're monitoring a patient on telly, and all of a sudden you see them go into VFib and everybody and their brother busts into the room and they're just sitting there with a mouthful of toothpaste because they're brushing their teeth. Okay, check your device, make sure it's working properly, make sure it's not something the patient is doing, right? Ever go into a patient's room or you're transporting a patient and you notice that they have really low blood pressure and you look and you notice that your automatic blood pressure cuff is now on the railing of the patient's bed? Check your device, make sure it's properly placed, make sure the waveform is a good waveform, look for a leak, and ensure that your system is functioning properly. It is a tool, utilize it as such. So, in summary here, end-tidal CO2 is an effective methodology to monitor patients' ventilatory and perfusion status. Our typical waveform I'm looking for is a rectangle, and it's not a perfect rectangle, right? Because we do kind of have that slopey edge up on phase 3 there. My expected numeric values are between 35 to 45, though I need to look at my patient and think about my patient's conditions and underlying conditions if they're below those numbers. Changes may be an early sign of decompensation. And things to kind of keep in the back of your head, anatomical differences. Children are at a greater risk of decompensation. So I appreciate you guys joining me today. Be on the lookout for the next couple of videos. The links for those will be posted as soon as I post them within the description of this video as well. Thank you for joining me, and I hope you guys have a great day.